Hello and welcome to the video. Today I'm going to be talking about understanding diuretics in terms of the pathophysiology and the clinical application, namely in managing patients with acute decompensated heart failure. This video is designed to follow on from the previous video on the cardio-renal axis, so I highly recommend you watch that video first to understand the basic concepts before watching this video. So let's get right into it. We previously talked about the Frank-Starling curve as shown here, and that the aim in heart failure is to try and shift the patient from the right side towards the left side of the Frank-Starling curve in order to optimize cardiac function. We also talked about the circulation system throughout the body and how there's an input at the level of the gut and an output at the level of the kidneys, and how there's an intimate relationship between the heart and the kidneys, which we've called the cardio-renal axis. We also talked about the body's natural mechanism to maintain euvolemia, known as the renin-angiotensin-aldosterone system, which, although is adaptive in the short term, is actually maladaptive in the long term, and that targeting the renin-angiotensin-aldosterone system underpins treatment of chronic heart failure. In the setting of acute heart failure, however, treatment involves trying to create a negative fluid balance in order to offload fluid to try and shift the patient from the right towards the left of the Frank-Starling curve to therefore optimize cardiac function. Logically, it makes sense that you can do this by reducing the fluid intake, which can be done by prescribing a fluid restriction, normally around 1.2 liters per day, or we can try and increase the urine output, namely through the use of diuretics. Now, in order to understand how diuretics work, we must first understand how the nephron is able to reabsorb sodium and water. This is a stylized diagram showing the afferent arteriole leading to glomerulus, and then the efferent arteriole, where there's the interface between the blood and the urine that is filtered through the Bowman's capsule into the nephron, which is shown here. Parts of the nephron are the proximal convoluted tubule, the loop of Henle, the distal convoluted tubule, and finally the collecting duct, which ultimately drains the final formed urine. While most of the filtered sodium is reabsorbed at the proximal convoluted tubule, a significant proportion of the sodium is reabsorbed in the ascending loop of Henle, as shown here through a channel known as the sodium-potassium 2-chloride transporter, or NKCC. Now, the purpose of this is to try and create a very high concentration of sodium in the medulla, and therefore a high osmotic gradient to allow water to then be reabsorbed from the descending limb into this medulla, whereby it can then be reabsorbed through the peritubular capillaries back into the circulation, which surround the nephron. Further distally, sodium can be reabsorbed in the distal convoluted tubule via a channel known as the sodium chloride cotransporter, or NCC, as shown here. And even further distally, sodium can be reabsorbed through the epithelial sodium channel, or ENaC, which is under the control of the mineralocorticoid receptor, or MCR, whereby when it binds aldosterone, or a mineralocorticoid, it leads to increased production of the ENaC, as well as a channel known as ROMK, or the renal outer medullary potassium channel, which leads to increased sodium reabsorption as shown here. And because of the function of the sodium-potassium ATPase, sodium is transported in one direction and potassium is transported in the other direction from the blood back into the cell, and because of the presence of ROMK, potassium is then excreted in this opposite direction, whereby sodium is being reabsorbed. These sodium reabsorption mechanisms allows for the formation of a very high medullary sodium concentration via the countercurrent multiplication system, which allows water to be reabsorbed into the medulla via water-permeable regions in the nephron, of which one of the main regions that is permeable to water is the collecting duct, under the control of the arginine vasopressin receptor, or AVPR, or otherwise known as the antidiuretic hormone receptor, whereby binding of antidiuretic hormone to this receptor leads to increased formation of aquaporin 2 at the tubular membrane here, to therefore allow more water to be reabsorbed into the systemic circulation. And you can see here how the renin-angiotensin-aldosterone system can exert its effects on the nephron by promoting sodium and water retention. So if we want to increase urine output or promote diuresis, one of the ways we can do that is by trying to target sodium reabsorption by blocking this. So one of the most potent diuretics we can use are the loop diuretics, which block the NKCC channel. We can also use thiazide diuretics to block the NCC channel at the distal convoluted tubule. And we can use mineralocorticoid receptor antagonists such as spironolactone or eplerenone to block the mineralocorticoid receptor and lead to reduced production of ENaC and ROMK, and therefore lead to reduced sodium reabsorption and also lead to reduced potassium excretion. So this explains why spironolactone or other mineralocorticoid receptor antagonists have a tendency to lead to patients becoming hyperkalemic, because it directly decreases potassium excretion. Similarly, using a drug such as amiloride, which blocks the epithelial sodium channel, will also lead to the same effect by reducing potassium excretion. And these diuretics are known as potassium-sparing diuretics, as opposed to loop diuretics and thiazide diuretics, which have a tendency to produce hypokalemia and increase potassium excretion because of something known as load dependency, whereby blocking sodium reabsorption proximally leads to an increased load of sodium distally, and therefore when it reaches this distal portion of the nephron, it leads to increased sodium reabsorption and therefore increased potassium excretion. And that is why practically using a potassium-sparing diuretic such as spironolactone along with another diuretic such as a loop diuretic or furosemide is quite a good combination, because the potassium retaining and potassium excreting effects sort of counterbalance each other. So when it comes to treating decompensated heart failure or patients in fluid overloaded states, the mainstay of therapy is usually loop diuretics, because they're generally the best single agent at inducing diuresis. However, it's not uncommon to see patients who are relatively refractory to loop diuretics, and that's because of the concept of load dependency and having more distal mechanisms to reabsorb sodium. And so sometimes in these patients, by adding a thiazide diuretic or even a mineralocorticoid receptor antagonist, you markedly increase the diuretic effect via this mechanism known as sequential nephron blockade. But the mainstay of treating fluid overload is still to use loop diuretics. And having a bit of understanding about the loop diuretic pharmacology can certainly help with the practical use of loop diuretics in treating decompensated heart failure. So in practice, when a patient comes in with severe fluid overload, we want to give them a decent dose of diuretics, usually around 2 to 4 times their maintenance dose. A typical dose would be 40 milligrams intravenously, or sometimes 80 milligrams intravenously, or as little as 20 milligrams intravenously. Intravenous furosemide is preferred to oral furosemide because of the wide range in bioavailability of oral furosemide. It is typically around 50%, however, it's been reported to be as low as 10% or as high as 90%, and giving intravenous or 100% bioavailability is probably the most reliable way to diurese someone, especially in the acute phase or when there's severe fluid overload. The actual effective dose also depends on the patient's renal function, because if you remember, the mechanism of action of furosemide is by blocking the NKCC channel from the tubular membrane. And so in patients with advanced renal disease with a reduced glomerular filtration rate, you're going to need much higher concentrations of furosemide in order to get enough furosemide filtered to block off the NKCC channels and to get any effective diuresis. So it's not uncommon for patients with advanced kidney disease to require doses of furosemides such as several hundred milligrams a day. But ultimately, when we're using loop diuretics to treat fluid overload, what we're trying to do is determine the threshold dose, or the dose where you're going to get effective diuresis. This concept stems from the non-linear dose-response curve of furosemide as shown here, where we have the fractional excretion of sodium or FeNA in the y-axis and the concentration of furosemide on the x-axis. Essentially, because the dose-response curve is non-linear, the significance is that when you're using relatively low doses of furosemide, you may not actually get any significant diuresis, but when you get to a threshold dose, you are able to get significant diuresis. And on the other hand, there's also a ceiling effect whereby further increases in diuretic dose will not lead to further increases in diuresis. So practically, I try and estimate what the patient's threshold dose is going to be. And so I give a starting dose, usually around 40 milligrams intravenously, or if they're very overloaded or they've got severe renal impairment and they're very fluid overloaded, or they have a high normal maintenance furosemide dose, I can use 80 milligrams intravenously. Or if they're a frail elderly patient and only moderately fluid overloaded, I would consider a lower dose such as 20 milligrams intravenously. But either way, you pick a starting dose and you have to assess the effect of that dose by assessing their weight loss, which will typically be around 1 kilogram per day, and that has to be fluid weight loss, or by monitoring their fluid balance and looking for about approximately 1 liter of extra diuresis from baseline. Once you have a dose which has that sort of effect, you know that this is pretty much your threshold dose, and then you can continue to give multiple doses per day if needed, such as once in the morning and one in midday. Now, it's relatively common to see people splitting their furosemide doses. And this doesn't really make sense from a pharmacodynamic point of view. Because, for example, you'll see patients getting 80 milligrams in the morning and then 40 milligrams at midday. Assuming the patient's threshold dose is 80 milligrams orally, you will get one lot of effective diuresis from that 80 milligrams. But at 40 milligrams, you're getting much less diuresis. And so that second 40 milligram dose is probably not doing that much at all. And so the key point is to try and find the threshold dose for the patient and use that threshold dose in order to optimally diurese the patient. And once effective diuresis has been achieved with diuretic therapy and the patient's weight plateaus towards their dry weight, you then want to down-titrate their diuretic therapy to either a maintenance dose or no diuretic therapy at all if they have mild heart failure and are able to adhere to a fluid restriction. However, in some patients, when you give high doses of intravenous furosemide as bolus doses, you can induce transient hypotension, which can get quite low and can get the patient quite symptomatic. Furthermore, if you're getting really effective diuresis of several liters per day, you can quickly shift the patient from the right side towards the left side of the Frank-Starling curve, such that they start to get down that steep left-sided portion of the Frank-Starling curve and can therefore precipitate worsening cardiac function as they get towards hypovolemia and precipitate a diuretic-induced pre-renal acute kidney injury. So in these situations where giving high doses of intravenous bolus furosemide is relatively contraindicated, you can use the furosemide dose-response curve understanding to your advantage by giving a low but constant dose of furosemide to induce constant low-level diuresis. And this is what happens when you give a patient a intravenous furosemide infusion, which can be an effective way to get patients to diurese significant amounts, but without getting sudden big shifts in fluid volume, and therefore mitigating the risk of having severe pre-renal acute kidney injuries from overdiuresis and from severe transient hypotension. So when patients present with acute decompensated heart failure, they're often presenting too far right on this Frank-Starling curve in severe fluid overload. They may even be so far right that they're in this downward sloping portion of the curve where they start to have compromised cardiac output, and this precipitates a pre-renal acute kidney injury where the patient will be in cardiorenal syndrome. It is important to recognize that in these situations, the only way the patient can improve is by diuresing the patient so that you can shift them towards the left of the Frank-Starling curve back towards this optimum cardiac output point, whereby improved renal perfusion will then resolve the pre-renal acute kidney injury. And so in these situations, the presence of a pre-renal acute kidney injury is not a contraindication to diuresis. On the other hand, you can get an elevation in the creatinine as you diurese the patient via several mechanisms, including decreasing venous pressure within the kidney and transient hypotension leading to hyperactivation of the RAS system and decreased glomerular filtration. However, it's important to recognize that these are usually transient worsening of renal function and shouldn't deter the continued use of diuretics. And when patients have a very flat curve in advanced cardiac failure, they often need prolonged diuresis to slowly shift them towards the left side of the curve, and when they reach this relatively dry point, they are then at this tricky trade-off of improving fluid overload but also worsening cardiac output and the pre-renal acute kidney injury. There are some situations where you do not want to give aggressive diuretic therapy, and that is namely in patients who are hypovolemic. That's because when you are hypovolemic, you are too far left on the Frank-Starling curve, and by inducing further diuresis, you shift the patient more towards the left and therefore can further reduce cardiac output and worsen a true hypovolemic pre-renal acute kidney injury. Similarly, patients with chronic liver disease, especially advanced stages, can also have effective hypovolemia where giving them aggressive diuresis, particularly loop diuretics, can precipitate something called hepatorenal syndrome. To understand this, we have to go back to this diagram showing the circulation of blood around the body. In chronic liver disease, with cirrhosis, there is essentially increased resistance for blood to flow through the liver. And this leads to a buildup of pressure in the portal vein because of the backflow of blood, and that is called portal hypertension. Now, the adaptive response is to induce the production of vasoactive mediators, which leads to the vasodilation of the splanchnic vasculature, which supplies the gut, which leads to more blood being pooled in this region, which therefore relieves the amount of blood in the portal system. However, this leads to less blood returning to the right side of the heart and therefore the rest of the systemic circulation, and there will be less effective blood volume when measured from the brachial artery when you're taking the blood pressure from what can be considered the peripheral compartment of the systemic circulation, whereas the central compartment is the splanchnic system where blood is being pooled in advanced liver disease. Because of this effective hypovolemia, the renin-angiotensin-aldosterone system is hyperactivated also in chronic liver disease. And so targeting this, particularly aldosterone or mineralocorticoid receptor antagonist, appears to be the most effective treatment in treating chronic liver disease in terms of preventing fluid overload. So this highlights the intimate relationship between the liver, heart, and kidneys, which I like to call the hepatocardio-renal axis, which via a similar mechanism to the cardio-renal axis explaining cardio-renal syndrome, the effective hypovolemia from pooling of blood in this central compartment of the splanchnic system in the setting of chronic liver disease leads to hepatorenal syndrome, where induction towards hypovolemia in a state of effective hypovolemia can worsen a prerenal acute kidney injury. And that brings us to the end of this video. I hope you now have a better understanding of diuretics in terms of the underlying pathophysiology and the clinical application in managing patients with fluid overload from decompensated heart failure. Here is a slide with the key take-home messages discussed throughout this video. If you like this content, please leave a like, comment, and subscribe to the channel. All the best.